let's begin with, first of all, I want to ask a very basic question that I think everyone asks at least once a year, and that is, why do my health insurance premiums rise every single year?
Yes, yes. And Roby, you're right. We're reaching that time of year where, most people are asked to choose a health plan for the next calendar year. And, for the most part, most plans are going to have an increase this year or next year over where they are this year. There are two main components to drive healthcare cost. One is the cost of the services themselves, or the price of the unit price, and the other is the utilization of that service and how often it's performed. And you take those two things together, and that ends up driving the overall trend. And for us, when we look at the non-prescription drug part of that trend, it's really utilization that's driving that. In fact, it's driving over about 70% of that non-prescription drug trend is due to utilization, increased services being performed. Now, on the prescription drug part of that, it's almost the exact opposite, where we see the price and the increases in the price of prescription drugs actually driving that part of the trend. And we've seen for several years that the manufacturers, and that's really what's driving it, the prices that the drug manufacturers are charging. And we're seeing multiple increases per year that's doing that. So that's really the reason why you're seeing an increase. We recognize that any increase creates a hardship for many individuals and for many families. I think for this year, probably the increases will be a little more moderate than maybe what they've been the last couple of years. But I think it's also important for all of us to keep in mind that really the cost of health insurance, if we're going to reduce the cost of health insurance, or at least reduce the trend, then we've got to reduce the cost of health care.
Let's break down the two components that you're talking about. Let's talk about utilization. You want people to use their health insurance. That makes them healthier if they are taking care of themselves or if they have an incident. So you don't want to discourage utilization, but at the same time, that's what drives the cost up. So how do you find some sort of equilibrium there?
I mean, we want them to certainly use the health care when they need it, and that's a big part. Preventive services, almost all plans now have some level of preventive services. We want them to use that. We want people to detect if they have a condition at an early stage as possible so that it can be treated before it becomes much more catastrophic. So you're exactly right. Not all utilization is bad, but when you see utilization that becomes redundant services that are being performed, or maybe they're unnecessary services, then that can add unnecessary cost to the system.
So let's talk about the drug manufacturers, which is the rising price of prescription drugs and how that is impacted. Is there anything that can be done to reduce that? Is that a legislative solution or a political solution? Is that a business supply and demand equation?
Yeah, I think right now it's all the above, I think is what it is. And I think, really to have an impact on those prices, we're going to need greater competition, especially for generics and biosimilar drugs. There are some proposals that have been made in Washington today, and Congress has in front of them. One is called the CREATES Act, and what the CREATES Act does is it begins to really address some of the things that brand name manufacturers do to keep from generics coming on market. So that's a bill that's out there. I think certainly our congressmen and our senators should consider and are considering support for that. There are other things. There's the pipeline of generic drugs. I think at one time there were over 4,000 different generic drugs that were in a pipeline waiting to be considered and waiting to be approved. More resources could go into that to clear that up a lot quicker and get those drugs out on the market. When you look at the average cost of a generic versus a brand name drug, it's typically anywhere from 15 to 20% lower for the generic. So it's important that we get those out there. And then another thing is what can be done around the patent protection that a lot of these brand name drugs have. Often you'll see that they'll be approved for one indication, for one condition, and then it seems like just as that patent is just about to expire, it'll be approved for something else, and they'll be able to extend it in some cases for about a 15-year period.
You tell me there's some gamesmanship that goes on with
this?
There
could be some gamesmanship that goes on with that, yes.
That would certainly be something that our lawmakers could take a look at. So let's talk about the business model of health insurance. You guys, to some extent, you negotiate prices with large healthcare organizations and providers, and that provides some sort of stability and predictability in terms of what the pricing is. As we've seen, it still continues to increase year over year, even though it may be more modest. We've seen years where it's been a lot larger.
Right.
Is that a business model that you think is sustainable for the future, or are there some things that you think need to change in that business model for the long run?
Yeah, I mean, I think for the long run, and it's something that we're focused on and really our industry's focused on, are really probably three key areas that come to mind. One is what can we do, and especially how can we use technology better to identify those patients, especially those who may have a chronic condition, and how can we engage with them as quickly as we can, so if they have one, or preferably even before they have a chronic condition, that we can do things to make sure they're working with their providers or taking care of their health and they stay healthy. Today, I think it's about 60% of the individuals have some form of a chronic condition. About 42% have multiple chronic conditions. So that's a big part of what we're dealing with. So you may have somebody, for example, who has diabetes, when they may also have hypertension as well. So their health risk is much greater. So how do we identify them as quickly as we can and then engage with them in a way where they want to manage their care and also to do that with their physician as well. So I think that's one area. I think a second area that we need to really be focused on and are focusing on is really how can we move away from the fee-for-service payment system that we've had today really for decades now for paying for health care. And in many cases that can encourage utilization, can encourage volumes of services. And so how can
redundancy too.
A lot of redundancy as well. So how can we move away from that and really move more to a system that reimburses and provides incentives based on keeping people well, not taking care of them when they're sick. And then finally the third thing is, and it's something that we've worked a lot on over the last probably 3, 4, 5 years, and that's this whole issue of social determinants of health. And that's become a kind of a phrase that's gotten a lot more attention in recent years, and that's really what it's referring to, or what are the social issues that keep somebody from being healthy. And so housing is often an issue, transportation is an issue, access to nutritious food is an issue as well. So what can we do as health plans and the healthcare system and all to work together to make sure some of these social issues are being resolved? So I think those are 3 key areas that us working together, all of us in the healthcare system, can make improvements and really begin to impact those costs in a major way.
Well, let's go back to technology, the first thing that you mentioned there, and tell me what's going on in terms of innovation that you are excited about. You guys have dedicated some money to UAMS to encourage more innovation, particularly in rural parts of the state, which quite frankly applies to most of Arkansas. Even highly populated areas are still rural compared to other places. What's your expectation for what your investment in innovation is going to do, and are there other things that you're doing in terms of innovation?
I mean, we share a vision with UAMS that digital technology can help improve access to healthcare services in our state. That's why we made a $1 million grant that was made to help fund the Institute for Digital Health and Innovation out at UAMS. We also believe that it can help improve affordability of healthcare as well. One of the first areas that the new Institute for Digital Health is going to be focused on is urgent care. And so basically giving individuals a way to access a healthcare professional if they feel like they need immediate health care or if they can wait for health care, and really give them some direction in an urgent, or what they perceive to be an urgent situation. We think that will help by reducing the amount of emergency room visits, which is a major issue that we deal with. It's a cost issue as well as just, it's not the best place to receive care. And so we think it can help with that. But probably what I'm most optimistic and excited about when it comes to digital health and digital technology is really in 2 other areas. One is behavioral health. We see in the news every day the importance of good behavioral health and improved behavioral health. We're reminded of that on a daily basis. And so we need to make it more accessible to people in all parts of our state, but especially in rural parts of our state.
You're talking about eating better, exercising?
No, really more around mental health.
Gotcha,
and providing some form of counseling and access to psychologists and psychiatrists, and doing that through digital technology and interactive video is a way to provide those services. Okay. We think that's an important area. Now it can also affect other parts, such as that you just mentioned. Somebody who may be have an obesity issue, some of that may be due to a mental health condition or behavioral health condition. So it can help address those types of things as well. But really providing that kind of care, which is desperately needed today, not just here in Arkansas, but nationally. So that's one area that we're very excited about, that this can really help with. The other one is around rural health care. And I think this past weekend, Rex Nelson had a very good piece in the Arkansas Democrat-Gazette about the challenges of rural health and the urbanization of Arkansas, and really what we're seeing in Arkansas is occurring throughout the country, where we're seeing more and more people leave the rural areas, move to the more urban areas to work and to live their lives. And what we're seeing is in too many cases, the most vulnerable are being left behind. And so we see digital health that can help with that, because as this, as the tax base declines in those areas, as the wage base declines in those areas, to be able to provide the medical services that are needed are going to be a challenge. So we believe that new models of care are going to be needed for rural Arkansas, and we think digital technology is going to play a critical role in those new models of care.
Arkansas lawmakers have been resistant to push forward aggressively on telemedicine. Arkansas is really one of the states that lags in telemedicine. I mean, is that something that you are doing more encouragement of with our policymakers to see if there's ways to make telemedicine more integral in terms of that delivery?
I mean, it is something that yes, we do want to continue to move forward, and we do want to advocate for that. But I think part of how we're viewing this is that really digital health should be part of an integrated healthcare delivery system. So to the extent that we can work with UAMS and other healthcare systems and hospitals and provider clinics around the state to roll this out, we think that's the proper way to do that. Now, it may take a little bit more time to get there, but we think that's the path that we're on, and we think it's the right path.
Catch me up on episodes of care. This is going to sound like an old question here, but I mean, it's been around since the Beebe administration, which is really where it launched there, and that has actually been quite a few years. We're probably 5-6 years into episodes of care. What are you seeing in terms of progress? Do we continue to see more types of care added to those episodic, to that lineup there? Where do we stand with episodes of care right now?
Yeah, and I think, Roby, probably what you're referring to is you're really seeing what are now being called alternative payment models that are really beginning to give rise, as opposed to the fee-for-service system that I talked about a little bit earlier. So what are some of these alternative payment models? The episodes of care, that's a good example, where you defined an episode and basically you tried to drive out some of the variation, and then you paid incentives in some cases.
So like a knee replacement
Exactly,
surgery.
A knee replacement was a good example of that. Now you're seeing those really expand into other areas, which is how can we reimburse and incent to again, keep people healthy versus paying them after somebody is already sick and needs treatment in that case. And so different types of these alternative payment models are beginning to take shape here in Arkansas as well as around the country. I think patient-centered medical homes is another that you're familiar with that I think we've had a lot of success with in our state. And really what that's intended to do is how can we transform primary care to make these medical homes for people so they have a place to start and seek their care, and then that medical home, these primary care physician clinics, really take care of them, and if they need services beyond that, then they'll refer those out. But it's to really promote team-based care. So you have a primary care physician, you have advanced nurse practitioners, physician assistants, a relationship with a pharmacist, all coming together to provide the care that's needed. You're identifying these high-need, high-priority patients, reaching out to them to help keep them healthy instead of them getting sick and coming seeing you at that point. And part of the payment model for them is to pay them care management fees, to pay these clinics those fees on the front end. So it's really not to treat a condition, it's to pay them for treating a population, their patient population. So Arkansas, we've been doing that at some level since 2010. In 2012, we began a public-private partnership with the federal government called Comprehensive Primary Care Initiative. And from 2012 to really within the last year or so, we've had a very strong program. We have over 200 clinics that participate today, over 700 different physicians. And just this relationship with the federal government has brought in over $200 million that the federal government has paid to primary care clinics here in Arkansas to help really provide that type of care management. So that's a good example, I think, of these alternative payment models that we need to continue to push forward in our state.
Is there a downside to that? Is there a downside to saying managing an episode of care for someone, let's just take knee replacement surgery since we talked about that one earlier, should it cost the same in Rogers, Arkansas as it should in Helena, Arkansas? Is that fair, or is it within a range? Is that how that works?
I think it's typically within a range. I think is how we've looked at that. But I think what it does do is it does, when we've had these programs, it has really led to providers themselves doing price comparison. Some are really transparency. It's brought transparency itself to say, if I'm going to send this case to somewhere, it's important that they know the cost of that, because cost does matter in that situation as long as your quality objectives are being met.
You mentioned too, I guess in that third rung on the ladder there, we talked about food insecurity and just the fact nutrition and things that need to be done to help people advance in terms of controlling healthcare costs. Why is food insecurity as big of a problem as it is? We live in an abundant state of food. There are a lot of ways for us to feed people. I know you guys have a lot of initiatives on this, a lot of other healthcare organizations too, but it seems to be a problem that we're making progress on. But it also seems to me, in a very simplified way, to be something we should be able to solve. We have food and a lot of access to it. Why is it so difficult?
2018 was Arkansas Blue Cross Blue Shield. That was our 70th anniversary. We were founded in 1948, and we kicked off an initiative last year, which was to basically, we wanted to give back to the state of Arkansas for helping us build this company. And so we identified a social area, social need that many Arkansans experience, and food insecurity is the one that we identified and said we want to make a difference in food insecurity. So we offered to go into communities throughout the state and to basically pack meals, working with a partner called the Pack Shack, which is in Northwest Arkansas. They provided the ingredients. Our employees went into these communities. We partnered with our customers, with healthcare systems, with faith-based organizations, and began to pack meals that went to these local food pantries. And we thought we would spend most of our time, quite frankly, probably East Arkansas in the Delta. We thought that's where the need was the greatest, and certainly there is a great need there. But when we kicked off that initiative, we were, I think, or at least I was surprised by how great the need was. The need is great in Little Rock, it's great in Bentonville, it's great in Fort Smith, in all of these places. And so we began getting calls and contacted by really leaders, community leaders throughout the state saying, can you come into our community and help us with this problem and do these meal packing events and really bring attention to this and help the people in our communities. And so we worked in over 50 communities last year. We packed more than 1.1 million meals that went to these local food pantries. But as we were doing that, in the process, we learned so much about food insecurity. And you're right, the issue is not just about food and the abundance of food. Part of it is having access to healthy food, which is absolutely critical. Part of it is income. We have so many people in our state, unfortunately, who are making decisions about what bill to pay this month. And in some cases, the food bill falls to the bottom. It's a transportation issue. We have food deserts where some of those are in cities and some of those certainly are in the rural areas where people don't have good transportation or reliable transportation to get access to food. We have an issue with family support, and we have an issue with education where a lot of people don't know what are the healthy foods to buy, how do you prepare those, and then really how do you plan meals around that. So all of those issues really need to be addressed to have the impact that we're looking for. Now, as far as is this a solvable issue? Certainly I hope it is, and it's one that we're working toward. We're very lucky in our state. The Arkansas Hunger Relief Alliance under Kathy Webb's leadership, they're doing wonderful work in this space. The Arkansas Food Bank and so many communities and churches around the state are really focused on this issue, and hopefully we're having a big impact.
Yeah, and I want to emphasize, it's not an Arkansas Blue Cross
It's
Blue
not
Shield problem.
That's
You are
exactly
a stakeholder
right.
in this with a lot of other healthcare organizations
That's exactly
and
right.
other outfits. Let's talk about the opioid epidemic. This is another thing impacting health insurance. It's impacting people's lives and the healthiness of their lives. What are we not doing that we need to do in terms of opioids and addressing this issue?
Yeah, I know in today's paper we saw an article about opioid prescribing rates here in Arkansas, and we've seen a decrease in the rate, but unfortunately we're still significantly higher than the national average. As a health plan, we see how it impacts our communities and impacts our members and firsthand and the impact that it's having on people's lives. So it's something that we've been very involved with for quite some time now. We try to do some things around prevention. We've put in system edits, so when opioids are dispensed at a pharmacy, it limits the numbers that can be received at that time, so you don't have an overabundance that's available. We've worked with Walgreens on safe medication disposal programs, so people have a place to get rid of their opioids when they don't need them any longer, rather than keeping them in their house. We provided extensive data sharing to the physicians around the state to show this is what their prescribing patterns are, in a way to hopefully give them the information they need to make changes. We've shifted really more to treatment more recently. We worked with the state drug director, Kirk Lane, on Narcan kits.
Right.
In our foundation, we've purchased kits for law enforcement and first responders throughout the state to help treat somebody who may be having an overdose and to provide that to them. We've removed the cost sharing that goes with, or the copays or deductibles that are charged when somebody has naloxone or Narcan prescribed for them or dispensed, because we don't want there to be a financial barrier to somebody getting this life-saving drug. But I think the area where we can do more is really around medication-assisted treatment. And what medication-assisted treatment is really using medications along with counseling and behavioral therapy to help somebody who's dealing with a opioid use disorder. The U.S. government now has said that medication-assisted therapy is the most effective way, or treatment is the most effective way to treat somebody who has that disorder. And really what it is, for example, there's a drug called Suboxone. And so when Suboxone is offered in combination with someone receiving counseling and therapy, then the possibility for sustained success with treating that is greatly enhanced, because what the Suboxone does, it helps control the cravings that the individual has. And so it allows them to not feel those cravings, so they have a better chance as they go through therapy to have a much more successful treatment plan.
Like a nicotine patch for opioid
Yeah, that's
abuse.
probably a little simple way to see it. But
To simplify things, Curtis, come on now.
I understand
Bear with
that.
me.
I understand that. But yes, but it is a way to look at it. It's to help them with that. I think the issue that we have in our state is that in order to prescribe Suboxone, you have to have a DEA waiver. And for a physician to have a DEA waiver, there's some training that goes along with that. So in our state, we have a relatively low number of physicians who have the DEA waiver that's necessary to prescribe Suboxone. So that's an area I think where we can have a big impact, and it's an area where I would like to see all of us who are involved in the healthcare system come together, and can we establish a goal and work toward meeting that goal, that by a certain date we're going to have a certain number or a certain percentage of physicians in our state who have that DEA waiver, so they can prescribe Suboxone or these other medications and make medication-assisted treatment much more prevalent than it is today.
I'm going to share your answer with a couple of state legislators and federal office holders.
Good.
So if you're all right with that. You're a big proponent. I want to turn our attention to the overall health insurance market nationally, as well as in the state of Arkansas. You're a big proponent of an individual market, a healthy individual market. You think that we may all rely on an individual market at some point. Why is that?
Right. Well, when you think about who's using the individual market today, who purchases their care through that, the self-employed, a lot of owners of small businesses, people, retirees who may not be 65 yet and eligible for Medicare, people who are in between jobs, or maybe their employer doesn't offer, they're not eligible for their employer health insurance. The gig economy, which is continuing to grow. So these are people who are mainly have their employment as contracted workers, or they're freelancers in many cases, and so they buy health insurance typically through the individual market, and that's a growing segment or category, within our economy of workers. And so it's important to us today, and I think it's going to continue to be important to us going forward. And if you look today at our uninsured rate, it's about 10% nationally are uninsured. Arkansas is about the same level. Most of that 10% comes out of people who could be or should be purchasing coverage through the individual market. We need for them to have coverage. We want them to have coverage. But there's several good reasons why. I think the first one is, we talked about a little bit earlier, someone who has health insurance is much more likely to seek care at an earlier stage and use their preventive benefits than somebody who doesn't. We know that providers who have high amounts of uncompensated care in many cases are forced to cost shift to some of their patients or categories of patients who have insurance in order to spread their costs in an appropriate way. Also, we have found that the larger the risk pools are, typically, the more predictable they are, and they help really provide more reliable and predictable health insurance rates for everybody else. So there's a lot of good reasons that we need, a strong individual market. And, when we look to the future and ways that we can do that, I think the first place that we need to be looking is what can we do today to basically improve the Affordable Care Act, the system that we already have in place to meet the needs of the individual market. And I think there are some changes there that we can make to make it where it's a much more stable than it is today or has been, and can help us really solidify that individual market.
I'll take a couple of your points on what do you think that would be.
Okay.
What do you think would help solidify that market in a bigger way? Individual mandate part of it?
Well, I don't think so. I think as we look at it, I think the first thing that we look at are the tax credits that are available today, or the subsidies that are available. I think, when the Affordable Care Act was passed, I think it was particularly heavy on the older workers or the older individuals, and to really provide some relief for them. And probably not enough was done at that time for the younger workers. And so we've seen, younger people, in a lot of cases, healthier people, they've chosen not to get health insurance because they feel like they don't necessarily need it. So
you're invincible when you're young, Curtis.
Exactly, you're exactly right. So what can we do to improve those credits so that it lowers the cost and will bring more of that younger population into the individual market? So I think that's the first thing that we need to look at. The second thing is you have the cost-sharing protections that are within the Affordable Care Act today, under the Affordable Care Act, so that the lower you are on the income range, then in many cases the co-payments or the co-insurance may be waived to make it more affordable for these individuals. Again, I think there's some things that we can do based upon age to help keep the younger people in this as well as income. So maybe up to from 250% of the federal poverty level to up to 300% of the federal poverty level, if we can extend that. I think a third thing is if you look at that individual market, about 5% of the participants in that market account for about 60% of the cost. And so what are some things that can be done either at the national level or at the state level to maybe create a reinsurance mechanism, and so that the carriers who participate in this can actually share the risk of these high dollar cases? And so we can pool some of that risk together, and if we have a catastrophic case, 1 year, then you get some protection from that. Next year it may be somebody in another state or another competitor, but at least it begins to level out those costs in a much more acceptable way. Some of the studies that have been released just looking at those types of changes have indicated that we could reduce overall premiums by as much as 33%. And so that reduces the cost. Again, it's going to keep people in the market if they do that. Plus, it reduces the amount that the federal government pays in tax subsidies as well.
So you're telling me there's a chance that someday I may see my health insurance premiums go down from 1 year to the next versus up?
There's a chance.
There is a raging debate going on at the national level right now. I don't know how this plays out because I think it will be determined by the outcome of the 2020 presidential election. So a lot of this is very hypothetical, but talks about Medicaid for all, Medicare for all, Medicare for some, maybe even a dual system where there is this bare bones government package and private insurance still exists as well for the market that is there for that. What do you sense is potentially going to happen? I know it, again, determines who the president may be or who the next Congress is, but what do you see if you look into your crystal ball in the next 5 years? Is it possible that we will see some big changes in that whole debate?
I think you make an excellent point. I think the next election is going to have a big impact on that, but I'm not one who believes that we're going to move to a Medicare for all system. I think part of the reason for that is if you think about why some people may be attracted to the Medicare for all is the for all part of that, which is it's basically a way to ensure universal coverage. And if we could do the kind of the common sense things that I just talked about with the individual market and really address that 10%, then I think we can hit that broad-based near universal coverage level by being able to take those types of actions. And we wouldn't have to disrupt the system, the 157 million Americans today who get their coverage through their employer. We wouldn't disrupt that part of that. So I'm someone who tends to believe we won't move, forward with Medicare for all, but I do think we are going to see some changes going forward, and I think that's just something we expect.
All right. Curtis, always good to visit with you.
Thank you,
so
Roby.
much for your insights.
You bet. Thank you.
All right.